think what I was most impressed with was how relatively easy it would be to leverage work that we had already done with a technical partner like Absalon to begin to approach an analytic strategy in a really new way.
So yeah, my name is Andrew Cusick. I am a senior machine learning engineer at Absalon, and I'm joined by Bill Adams from BMC. So Bill, would you like to introduce yourself?
Sure. So I'm Bill Adams. I'm a pediatrician and also lead up the translational informatics research group at Boston Medical Center and Boston University School of Medicine. And then I also do quite a bit of work managing electronic health record systems for our partner community health centers in Boston.
Excellent. So for context, you were working actually with our app team at Absalon to develop a dashboard for visualizing patient data, run some statistical analysis, and build some kind of simple logistic models. So we at the ML team were obviously very interested in this, and we wanted to run a short POC, proof of concept, with you to use some more advanced machine learning techniques. So I guess that brings me to my first question, which is if you could talk a little bit about the data that you have and how you think machine learning generally could be used to improve healthcare or improve the insights that you gain from that data.
Sure. So as you know, we spend a lot of work on my team in organizing and standardizing electronic health data. So we take the data from the electronic health record and transform it into something we call a common data model, which is a standard way of representing data. And then for this project, we did quite a bit of work to pre-compute a portfolio of outcome measures, and then also pre-compute a portfolio of exposure attributes that could be used in models to better understand how, in a multivariate way, features of patients predict or are associated with certain health outcomes. And in Boston, our health system predominantly takes care of marginalized populations with often an experience of racism and then also financial insecurity. And so we are really interested in both clinical features of patients that predict their health outcomes, but also social features. And I think we had some really nice success in more traditional epidemiologic approaches to studying these relationships. But we were excited to think about how machine learning techniques and more advanced analytics could be used to automate, explore, perhaps discover new insights that we weren't able to achieve with the more traditional approaches.
Yeah, so I think one really important thing off the bat to talk about here is that with the common data format that you're using, the kind of application of machine learning to that format wouldn't just be applicable to, you know, yourselves at Boston Medical Center and your patients, but also could be applied, I guess, across the country for other institutions that use the same or the similar data models.
Absolutely. I think there's two important ideas here. One is that we use a common data model so that the analytics that we develop could be used at other sites that use the same common data model. And it's not just the United States, actually. The OMOP common data model that we use is an international standard. And then also the pre-computed standard, many systems could feed into the pre-computed data mart that's used for our work in this proof of concept. So virtually any system could feed that framework as well.
Excellent. So I'll briefly touch on what we looked at for the POC. So when we spoke, it was kind of clear that we were interested in looking at both unsupervised and supervised machine learning techniques, but maybe we were a little unsure as to how they could actually be applied in reality. So what we did at Absalon was to build a quick proof of concept to take the data in the OMOP common data format, and to initially run some unsupervised clustering on it to kind of create subpopulations of patients. And then in order to make sure we had some explainability behind it, we built a classifier on top of the clustering algorithm to understand what were the features in the data that were most important for placing patients within a certain subgroup. So yeah, I guess my question generally to you is, what did you learn coming out of the POC, and did it kind of make the path a little bit clearer for you in terms of how we can use machine learning on the data that you have?
Yeah, I think in this pretty quick and brief proof of concept activity, I think what I was most impressed with was how relatively easy it would be to leverage work that we had already done with a technical partner like Absalon to begin to approach an analytic strategy in a really new way. And so we're quite happy with what we have right now, which is a more traditional approach. But we also recognize that electronic health data is sensitive. And so it's actually not that easy to partner with external experts to actually bring advanced tools into a shared workspace. And so it actually was pretty easy to do that. I think we were able to quickly implement what you had done with a little bit of help. And while the findings, we'll still have a ways to go to actually develop outputs that could be used in everyday clinical care. I think we've demonstrated pretty clearly that the approach is feasible, that the tools can be applied fairly quickly, and that there's a lot of possibility and opportunity.
Yeah, definitely. I agree. This was an initial proof of concept, but and there would still be a long way to go before we could get some actionable results output. But I think from the discussions that we had, there's a lot of different ways that we could go with this, that make it really, really interesting. One of the things to highlight is that in order to run this POC, we obviously didn't use real patient data. But since we're using a common data model, we were able to actually, BMC was able to produce some synthetic data that we could initially build this POC on, and it meant that we could develop it internally at Absalon and then afterwards ship it to BMC so that they could run it on real patient data. So one kind of going on to how we could see this progressing and kind of actionable insights that we could get using machine learning models. One specific implementation would be to understand patient trajectories, how well patients are doing over time, and potentially recommend interventions or changes in treatment based on the visits that they've had. Could you talk a little bit more about this and how it might work in practice?
Yeah, I guess when I think about the potential value of machine learning algorithms in clinical care, I think of them at multiple layers. Of course, there's always the point of care application where the clinician is seeing the patient. And if the system is able to understand enough about an individual patient and their previous history to recommend treatments based on either challenges or struggles or inability to meet a certain level of control or quality in the past, or an existing trajectory of already doing well, it can deliver personalized recommendations for individual patients that are way more likely to be effective. So clinicians are very busy. They're rarely able to look at the entire record in quick time. And if the system can understand an individual person's trajectory and recommend changes in therapy or new approaches or augmentation of support systems based on a predictive algorithm, that can be super helpful. But the same strategy could be used at the clinic level, where groups of people are identified as either being likely to do better, likely to stay the same, or likely to do worse. And interventions and care plans can be tailored to those groups. And even at the health system level, system-wide recommendations could be made based on similar algorithms on a larger scale. And then finally, we recognize that a lot of interventions to help people are not necessarily based in the health system itself. So if health systems could work together, policymakers and people who decide about what happens in cities and states and countries could use these data to better support strategies to advance health equity, which may not always involve a clinical intervention. It might involve a societal level intervention. And so I can imagine these tools being helpful at all those different levels and probably other levels that I haven't even mentioned.
So one of the things that you've already touched on is healthcare equity. So could you talk a little bit more about that, why it's important, and how you think that maybe gaining some more insights from the data that you have using data-driven methods could improve equity in healthcare?
Yeah, so we recognize really well in Boston that not all groups experience health equally, and it's due to a number of factors. We believe that a major driver of outcomes, at least in Boston, are what we call systemic race-based issues, systemic racism. And while there is also a good deal of individual racism, these things have been perpetuated over time, and in particular, large socioeconomic differences also exist in Boston. And so when we think about equity, it's really about measuring clinical features that are impacting patients and health outcomes, but also societal features as well, the features of the places where people live in their neighborhoods, and the life experience of individual patients that we understand from standardized surveys. So in our models, we include all three of those data domains: rich clinical data, information about where people live, and then also self-reported challenges with socio and environmental issues. And so we then can tailor interventions to support those measures, because equity itself isn't so much giving everyone the same thing, it's giving people what they need. And so if a group has been disadvantaged, they don't just need the same level of support as folks who have generally been doing well. They might need 2 or 3 times the support, or they might need a different type of support. So getting to equity is that everyone achieves the best possible health outcome. It doesn't mean that everyone receives the same amount of care or support. And to achieve that, we need tailored approaches that both understand how best to deliver what's needed, but also to monitor that process over time, because what's needed could easily change. So it's both informed, directed support for subpopulations of folks, but then also a process over time that monitors that and adjusts to what people need as time progresses.
And would you be able to give some examples of what that may look like in practice? Maybe what some interventions at that kind of subpopulation level may be in terms of equity? Yeah,
so there's kind of 2 things that we use a lot of where I work, and they're a similar type of extender resource. So navigation is an idea that's quite well understood and has been used for a long time in Boston, whereby a group of people have a need that requires extra support, and then we have navigators who can help people achieve that. So for example, if a subgroup of patients is having difficulty with diabetes controlling their blood sugar, whether it be race-based or economic-based or age-based or disability-based, assigning that patient to a navigator who can call them regularly, can help them get the medications they need, help them understand how to use the medication, may well increase the likelihood of achieving diabetes control, for example. So when you can tailor interventions, either medication prescriptions or procedures delivered or personal support services to subpopulations, you're more likely to get them to achieve the health outcome that you're targeting. And for diabetes, it's often blood pressure, blood sugar control, as reflected in your hemoglobin A1C. Another example would be people with mental health conditions may well have disparate health outcomes, like their blood pressure might be less well controlled or their diabetes might be less well controlled, and directing them towards support services for mental health or behavioral health is going to increase the likelihood that they'll be able to achieve the health outcome and the control measure that we're targeting. So things like that, where the data system understands what individual people need, and then the infrastructure helps deliver additional supports in that space so that the group that's disadvantaged achieves the same health and health outcomes as the traditionally advantaged group.
Another thing that you touched on was the environmental and social factors that could contribute to patient health. And I think this is a really interesting way that we could go with the machine learning, where we use clustering techniques based on, for example, people's location, to understand how these factors may be affecting health at a more macro level. So could you maybe describe some of the data that could be used here and how you could kind of understand patient health from this higher level?
Sure. So in the our Shiny app that we built with Epsilon, there's kind of three different domains of analytics that we let users explore. One is a traditional kind of run chart data table. Another is a self-service logistic model. But the third component are geospatial maps that can visually help users see how a place-based risk factor like low economic status can be overlain on a map of blood pressure control for the city of Boston, for where I work. And so we think of drivers of health as being clinical drivers, so things about individual people and their biology and their life experience, but also about the features that influence their health based on where they live. And we divide those up into social and economic features, opportunity, safety, a whole variety of things that are local to where you live, but also environmental. So access to green space, air quality, temperature, all those things are likely to are being shown more and more to influence your health. And so we do a lot of work to geocode the addresses that people report when they come in for visits. So pretty much we know where our patients live every time they register for an appointment. And so we can, in a privacy preserving way, link any feature about the place where a person lives to the health that they experience, and we can put those into the same data model. So traditionally, prediction and analytics within healthcare data systems has been limited to clinical data. But in this new way of thinking, we also bring in social features about the places where people live and environmental features as well. And so in this way, policymakers can begin to think about the health of people living in a neighborhood or people living in a defined area of a place that they have influence over, and can begin to think about making decisions there. So what I've said in the past is that in this way of thinking, the health system isn't necessarily the thing that drives the health outcomes, but it's the way that health is measured. So because people come in for healthcare regularly, we can monitor the health of a population, but you could imagine that 80% of the work of improving people's health actually happens outside of a health system: education, economic opportunity, safety, and any number of features that are worked on by folks who don't work in healthcare, and that those could be just as important or more important in improving the health of a population. So that's how I think about it. And we just have all kinds of opportunity as we bring in these new place-based data resources to expand the way we think about health and health outcomes and health disparities and health equity.
Yeah, so I think for me this has been one of the key takeaways, which is there's actually, you know, a wealth of data that's already out there that exists, but we haven't necessarily been able to fully tap into it or you know, even begin to tap into some of the data. So it makes the idea of using these kind of data-driven techniques, using machine learning, really appealing if we can do it right, because there's so much data out there that we can derive insights from.
Yeah, a good example of that is, so for us, we just pull in 3 publicly available place-based data sets from the US government. One is called one's supported by the Centers for Disease Control. It's called the Social Vulnerability Index. Another one is from the Census Bureau, called the American Community Survey. And then there's a third one that's actually from a local university called the Child Opportunity Index. But just those 3 collections of place-based data elements have hundreds of variables, and being able to leverage all that data outside of a traditional logistic model, I think is going to require machine learning techniques to find the most important ones and to leverage as much of the data as possible. And those are just 3. There are so many more rich data systems. Air quality in particular can be very, very deep and large in terms of data resources, and how to pull out what's most important in those systems will require tools like this in the future, I think.
Yeah, absolutely. All right, well, that is all the questions that I had for you. So yeah, thank you for the time, and I really enjoyed working on this proof of concept with you, and I'm hopeful that we can do some more work in the future to really bring these sort of techniques to actionable insights for healthcare.
Me as well. Thanks very much. It's been great working.